Plumas County Public Health Agency, growing healthy communities.
So we're going to talk about this particular part of prevention of opioid addiction and the deaths that can occur. But we know that prevention is a big topic. Maybe we'll touch on that just a little bit later, because most of this has been about harm reduction, right? We've seen some amazing stuff about harm reduction, and of course that's a hot burning fire right now that we know has to receive a lot of attention. But ultimately, looking at generations and this huge opioid epidemic we're having, you know, we need to be thinking obviously about prevention as well. So I might just move this if I'm not to use it. We'll just talk a little bit. So here we go. Defining the crisis. 2011 in Plumas County is when we really began to recognize that we might have a problem. I work in the emergency department, and you know, there were too many overdoses coming in. Some of those people would come back. A month later, we would talk to their primary care doctor and say, hey, you know, you're for an overdose, you know, we've got to do something different. And yet they'd be back in a month, right? Younger people were coming in with high potency opioids like methadone and oxycodone for non-cancer related pain. I know some of those people have pain, they deserve treatment, but we know that opioids are usually not the best treatment for that. Older people were dying, and when we looked at the coroner's toxicology report, we find opioids, you know, and benzos combined, right? I mean, all these red flags, but we didn't see all the statistics. Certain doctors went on vacation. You guys, most of you have probably seen this. You know, the ERs, all of a sudden there's people coming to the ER, can't get my prescription refilled. So what do? And the state data, which is now widely available on the state database, you know, although this 2017 stuff which is posted. But back in the day, you know, that really wasn't as easy for us to see. So it was the fact that we realized there was a problem here that really helped us get going. So around 2012, we really began to address the problem, and I'm just going to basically recount the story of what happened and what we did, and hopefully some of that is useful to others. Once again, 2012, we had 6 times, now we know retrospectively looking at the data, 6 times the incidence of prescription opioid-related accidental death in California. By 2014, there were, you know, red lights going off, the state was calling us to say, what are you guys doing up there, et cetera, et cetera, et cetera. So, but we were really already kind of working on this problem, and, you know, we actually, I'm very proud of this number. There's only a few counties in the state that have reduced prescription opioids by 61%. That's based on morphine milligram equivalents. It tells all the number of pills, the potency, that stuff. Okay, but it's a wonderful statistic. And then the death rate dropped dramatically, and you know, we were up to 9 deaths one year, which was a lot in the county of 18,000. And 2016, we had 0 deaths. 2017, we had a couple. So far this year, we're good. So yeah, we still got a ways to go, because the state, according to state averages, Plumas County with 18,000 people should have 0 to 1 death per year. You know, a half a death, 1 every 2 years, right? Okay. So we're still over. We still got a ways to go. And how do we do it? And you know, glad that we can talk about that. This is just the graph, try to pretty it up, you know, but there you can see it got down to 0 in 2016. We're, like I say, proud. One of the things that we become aware of is that death certificates are often imprecise. So it's easy for the coroner to write on there, death due to alcohol and multiple drug toxicity. Well, what are the multiple drugs? I mean, did they overdose on, you know, Benadryl or, you know, Cytoxan? Or, you know, you don't know. And you don't know whether they're prescription opioids or IV opioids, okay? But I will tell you, in our county, in 2012, 95% of the deaths were prescription opioids, only 5% IV. Nationwide, it was different than that. It was 2/3 for prescription and about 1/3. So anyway, one part of the difference in our ruralness is we didn't have much heroin then. Wish we didn't have heroin now. Okay, we have lots of heroin. And this is just our prescribed opioids, and just to make it stand out, when I made this graph, I had to make ours dashed, you know, because it was so. But we're so pleased. And you know, you have other counties on there like Siskiyou, Shasta and Butte. Look at Shasta and Butte. You know, this is their prescriptions. Let's see if this pointer works. See, they're prescribing almost twice, or no, 30%, 40% more than us back in 2012, and they're still now almost twice where we are. And the California average is this gold line at the very bottom, or green, whatever. That's what the California average is. So it shows you how much some of these counties are prescribing opioids above the California average. And we were part of that, and we're still a little bit above, not much. And the gray line there is Sacramento. I thought, let's look at a big city, that has a lot of resources thrown at this and all of the urban stuff, socioeconomic and stuff. So that's the data. And then, of course, I know this is really hyper busy, but I had to have this before I could do the graphing. But there's Plumas County back in 2012, 1,441, and then Plumas County now is down to 569, right? So again, we're just proud. So there's where the 61% comes from, and there's a little stuff on deaths, and the rest is stuff we already talked about. There are numbers. I do think these slides are going to be posted on our county and public health website, by the way. So if you get home and you think, wow, what was that percentage, or what were those other counties? I haven't talked to James about it, but I do think they're going to post them up there. So hopefully it'll be better. Okay. So what did we do? These people are in pain, right? That's the first thing we have to acknowledge. They're in pain and they're hurting, and they need to be evaluated appropriately for pain. Well, I do that in rural areas. All family docs. I'm trained as a family doc. Pain specialists. So, it was Eastern Plumas Hospital in Portola. It was the first one that had really the light went off and said, we need to get some pain specialists coming here. And they did. They hired some people. They're not here full time. But they did get the ball rolling, and that turned out to be a benefit to the whole county, because those people then came and talked to us in Quincy and around the county. Anesthesia, physical medicine, I won't dwell on all of these. So one thing they did up there in Portola, all chronic non-malignant pain patients were asked to consult with one of the pain specialists, and then go back to the primary care provider. And then sometimes they were put on taper, but the medicines were adjusted. The other thing I wanted to mention, it wasn't in my slide, but I remember today when the folks from Austin, Indiana were talking, or Scott County in Indiana, it's people in pain need an adequate workup of their pain. We need to, not only we need to give voice to it being important. Yes, go ahead.
I was wondering about the ease of getting that referral, whether the pain specialists were accepting those referrals, or if that would become a difficult thing depending on their insurance coverage, or...
Right.
It
wasn't for us because we had plenty of pain specialists. It just happened that our CEO of the hospital in Portola was adept at getting people involved. However, I think in more urban areas, it's a huge problem. There's a shortage of pain specialists, right?
Right, other rural areas as well.
And other rural areas. So that, my last point here, but they do need a workup, and I think the woman talked about that tragic episode of somebody who had bone cancer, was not diagnosed. Yeah. So when the pain specialists give us grand rounds or talk to us, one of the things they talk about is the evaluation these people need. Not only we give voice to treating them appropriately, but we go, investigate what's causing their pain. So that was my last. Pain specialists are often hard to come by. Two things: telemedicine. We've used telemedicine both Quincy and Portola for that. I know we do telepsychiatry here in Plumas County, which has been really helpful to getting that therapy to our patients. And then Project Echo is a wonderful thing. It was kind of invented in New Mexico about 15 years ago to improve the care of hepatitis C patients who weren't getting great care out in the boondocks. And they linked up with the University Medical Center and had the hepatitis C specialists on the video link, telemedicine, right, with a whole conference room full of providers who were taking care of these patients, and they could present the case and say, well, everything looks fine with most of these people, but this one we got a problem. What would you do, And we're talking 100 miles away or something, right? So that Project Echo has expanded now. Renowned Hospital in Reno has Project Echo. A lot of it, I think UCD has it. And of course you just dial in, right? So, and there may be their fees. I don't know all about the fees, but it's a great idea, and it really brings telemedicine and can bring superb pain control to the boondocks. Okay, so we can talk maybe later. I would check with Renown, UC Davis, and see. And it's called Project Echo. If you search on that, Google it, you'll get there. All right. What else do we do? CDC guidance for treatment of non-cancer pain came out in February of 2016, but most of the precepts of that have been known at least for a number of years, and I'm going to click through them pretty quickly. if anybody is curious about some of these things, it's all available on the CDC website. It's been discussed and published. All right, so we can get the message out to all the regional doctors and other health care providers. I encountered healthcare providers that said the CDC said what? I don't care what the CDC says. What do they know? You know, I'm going to do it my way, and I'm not the one that's working out here in the boondocks taking care of these people. So, you know, it can be done. This is not magic just because the CDC says we should do it, even though I believe the CDC is an excellent organization. This is all solid stuff, right? So I don't know how you get past some of those things, but we at least made the effort, and I think it really helped, right? Then we got our Healthcare Foundation grant, 2015, public health, and we started the Northern Sierra Opioid Safety Coalition, 2016. Now we'd already been working on this, right? So we kind of had the wind at our back in some senses. But at the same point, this formalized the process, and here were the goals. Reduce opioid prescribing, we'd already been working on that. Increase availability of medication-assisted treatment. And that was something we jumped on over at public health, and now it's expanding really throughout our county better. This is tough. And my comment on that is it's not just about finding providers to get the waiver, it's about all the support these people need, these clients, whatever you call them. They need a caseworker, and they need behavioral health consultation and counseling, they need substance abuse counseling, and it's the whole package. It's the other 80% I tell people, okay? So yeah, get a provider, and that takes the burden off the provider. If the counseling's not adequate, the providers always have answering questions about the family struggles that people are having and their cravings and all this, which are better addressed by people who understand addiction maybe better than we do as clinicians. And then naloxone availability, our county's done a great job on that one. Now we're saving lives, you know, routinely with the injecting epidemic. So am I going too fast, too slow? Questions? Any other questions? Okay. Yeah.
How are you getting in the naloxone now?
So I'm not the best to answer that, but I know James, who you've met, who has been leading our conference, is integrally involved in that, and we have a van. But from day one, this is 2-3 years ago, we've been working with the other counties like Sierra County, Lassen County. What are you doing about naloxone? What's the actual mechanics? I think we've gotten grants to pay for quite a bit of the naloxone. And then we've just been very proactive. You cannot hurt people with naloxone. Yeah, you can take them out of their stupor state, where they're high as a kite, and we might be angry at you, but literally you cannot do physical harm and kill them. Yeah, they're angry. You know, I work in an ER, right? Give them too much naloxone and well, it's something to deal with. Yeah. However, it's not killing them, right? It's not killing them. So it's very hard to do harm with naloxone. So we right away jumped right on that and said, so I don't know what that answered.
I can answer that probably a little bit.
Pardon me?
I could probably answer that a little bit.
Yeah, please.
So, through the public health van where they're doing their syringe exchange, there's naloxone available there.
Okay.
We also have people in our jails. As people are being released, they're being given naloxone. We have some crisis centers and nonprofits here that also are distributing. You can get them at behavioral health or public health. So there's a lot of access in the county to that.
How about the physicians?
So-
Are they prescribing it at a certain?
So mostly that's a little bit more of a question in the sense that naloxone is spectacularly successful at saving lives of people who are shooting IV, heroin, and opioids. There's some debate about how successful it is. There's not a study out there yet that shows it saves lives in prescription opiate users. Why? We're going to talk about that a little bit later. Okay.
Okay.
So there is a big movement to get all the doctors prescribing Percocet and whatever to prescribe naloxone, and it is available in our pharmacies, but we've not had the big push to get the doctors doing it for the reasons we'll talk about in a little bit. It's a different dynamic. The way they go down is a different dynamic. So let's talk about that. But I run the medication-assisted treatment clinic here at our health department, and every one of those people that comes in, we talk to them about clean syringes, we talk to them about, do you have naloxone? And James, in person, comes down to the clinic and talks with the people and hands them a bag of Narcan. Yeah. So, yeah. But getting out in the community, it is important. All right. Sought and received support from the healthcare organization administrations. It was Eastern Plumas, again, that really highlighted this for me. is that they really felt it was so important to have their board of directors involved, their administration involved in this process, because there are going to be some complaints. You know, it's a hard thing to do, but particularly about the complaints, and this is a venture that's well worth doing. Enhance patient safety, and I'm talking about reducing the prescribing now, right? Improve quality of pain control, right? Opioids have been shown not to really help, like long-term. You know, there's opioid hyperarousal syndrome. Those of us that are doing this work, we see people on a daily or semi-daily basis who are so happy they're not taking that stuff and their pain is better. It's better. The opioids were not helping their pain. They thought they were, and then, you know, organizational leadership, you know, that goes on here with them. Help through a period of increased pain. Some of these people are tapering, right? We have to be there for them and show that we do care. We're just trying to save their life, right? Anticipating increase in complaints, and of course, providers now getting rehired or getting your contract extended has a lot to do with your satisfaction survey. You know, and so some providers are really, they're actually very worried about that, because if I tell people, it's how you tell people. It isn't telling them, you know, we're going to cut your backs, how you couch it and taking the time with them. But nonetheless, it's important to address this, that the providers will not be, you know, the contracts are not going to be canceled because somebody's paying us in back if they did it appropriately, and et cetera, right? We can't just stop it. We've had providers do that. Then the people go out and they go get heroin and start shooting heroin, right? When you cut them completely off of their oxy. Providers do overwhelmingly want to give great care, right? I mean, come on, especially in these rural areas, it ain't that pretty out here. Educational opportunities, pain specialists. So the pain specialists we hired did this. We did the telemedicine. We had grand rounds, the next bullet. Quincy, we had 5 grand rounds over a 2-year period on the evaluation and control of pain and safe use of opioids. So that's really important. I think providers want, we talked yesterday about academic detailing, which can be a good part of that, but I actually think as a provider, I don't want to be detailed. You know, detailing is what the drug companies do. So if they called my office and said, hey, you know, I want to come talk to you about opioids, I'm thinking that's Purdue Pharma wanting somebody more OxyContin. And tell, yeah. So I was actually skeptical. I think a lot of providers are kind of skeptical about any detailers. Yeah.
Can you speak a little bit on some successes and challenges that you've experienced in Plumas County with academic detailing?
Not in Plumas County specific. I know that we've had some, we have half a dozen people that have been detailed. And I know that a couple of those people were people who are high prescribers, but it's too early. So that's one of the things when we talk about academic. It's in the investigatory stage right now, and we're part of a study that's going to define, does that work to decrease prescribing? And that's what they're really doing right now. So we know that if the detailer comes to the doctor's office or the nurse practitioner's office and says, hey, Augmentin is the best thing for a cold, the prescriptions go up for Augmentin in the pharmacy, right? That has been shown over and over and over again. Doctors and providers don't believe that's true, but it's most definitely true. So in theory, academic detailing should work. But when it's been, even when it's been tried in areas like Augmentin versus it's a viral illness, the evidence is not absolutely clear that it does work. And when you're trying to talk a doctor into reducing their prescribing, which you get a lot of pressure from the patient to prescribe these opioids, I have a certain suspicion. I'm not sure how well it's going to show up in the long term to work. So providers came to the meetings. Ultimately, primary care providers enjoyed increased success with their chronic pain patients. So this was kind of the summary of what happened with providers. Some of the providers were not the problem. Some modified their habits. They want to be good docs and good FPs and PAs, etc. But we did have one doc in particular whose contract was not continued, partly because of this. Another couple retired, some left the area, and we had one doc in our county that was sanctioned by the DEA. Lansing County also had a doc who was sanctioned. And you talk about that really sends a shockwave through the medical community. And doctors really pay attention. They might have been kind of thinking, well, that's okay, it doesn't involve me. And then when somebody they know is sanctioned by DEA, sorry, but that's just the real world. You know, it's like when you see the highway patrol sit alongside the road, you look at your speedometer, right? So, yeah, I just put all these on one slide. Again, a lot of this is stuff that's on the CDC website that we've been doing for years, but we just wanted to make sure to formalize the process. Although I'll drop down to the second one from the bottom there. You know, I think we do need to look at marijuana, because I personally know people, I don't do marijuana, you know, but a lot of people do, where it does seem to really help with chronic pain and their anxiety. And it's safer than benzodiazepines combined with opioids. Come on, you know, people do not die smoking marijuana. There's other issues you can go through. So I think it's important that we be at least not throw people out of the clinic because they're test positive for THC. And then, you know, missed appointments. There are some clinics, if you've missed, you know, 3 appointments in a 6-month period, or out permanently, etc. I think we need to rethink that too. Treatment of opioid addiction requires us being engaged in trying to keep people in treatment, right? So I know it's tough. And you guys probably have better rules than I have. You know, you have to have rules, right? But it's important that we all understand we want to keep people in treatment. So I think we're doing okay on time, probably. I'm 1.5 halfway through, probably. Yeah. Let me know.
You're about, you got 30 minutes.
Can you go back one slide for 1 second?
Oh, sure. Was it this one or, wait, sorry. Where were we? Was it this one? Yeah. No?
No, one more ahead.
Okay. Yeah,
That's it.
yeah,
I just wanted to respond.
yeah. And like I say, I think the slides are going to be available on the website too, if you guys care to have to see them. So we don't spend too much time on the detail. Okay.
Okay, great. Thank you.
So, and there's opinion expressed and whatever there. And then, you know, this one I almost dropped it because there's a little conjecture here. We do need to respect patients, obviously, but I think we need to respect providers. That when a provider is doing something we maybe don't think is optimum care, there's often, we need to explore the reasons they're doing that and explore, this is what we're talking about in academic detailing, and the academic detailers go out and they sit with the provider. Well, now why is it, you know, you feel you need to keep doing this or refill this, or we can't try to taper? And so we all need to acknowledge that, you know. And then I mentioned, you know, we providers, it's all about evidence-based care, right? And with pills, it's very easy to do a double-blind, placebo-controlled. But with a lot of other things, a lot of alternative treatments and so forth, it's not so easy. Acknowledge that not everything can be, can be shown in double-blind fashion. And also, so if somebody is doing something that we think is a placebo treatment, that's working for them, it's not causing them harm, it's not costing them an arm and a leg. So, you know, do we need to give them a lecture about how that doesn't work? I don't think that's effective, right? Or we don't think it works with all our authority. Okay, academic detailing you heard about yesterday. The very bottom bullet there, thus far there's limited evidence of effectiveness, in other words, fewer people dying and less prescribing. However, the studies are going, and what else are we going to do? You know, we've got to do something. We've still got a lot of providers out there prescribing way too much. And I don't know, just look at this. We talked about academic detail. I'm not going to repeat what they talked about yesterday, and, unless there's specific questions about academic detailing up there. Some things are effective in other communities, okay? So our Medicaid managed care plans, California Health and Wellness Anthem, Blue Cross, they have not been particularly aggressive on this. I don't know, Andy may be able to correct me on that. I don't think they have. But certainly, certainly other agencies like Kaiser and Partnership Health Plan, major part of their state, have been very aggressive and very much tuned in on what can we do to help this problem, to help solve this problem in a compassionate way, and help providers do it. It doesn't take their whole day getting a prior authorization for stupid things. Okay, so just to point out that there are some things that didn't happen in Plumas County that can be effective other places. And then I just put a couple of slides here about rural providers, what I think some of the ways rural providers might be different than urban. And again, I'll just drop down the whole slide here. But short supply. So suppose you have a provider that's overprescribing opioids and you can't seem to get them, you're having a lot of trouble getting things under control and as appropriate according to your methodology, but you don't have somebody to replace that for someone maybe, you know, or a doctor. So you got to deal with those problems. They work long hours, take a lot of call, deal with complex medical problems that are very anxiety-provoking and emotionally draining, and so forth. We're isolated. It's hard to get high-quality CME, although the internet's helping that, right? And the bottom one I think is important because not infrequently this person who's on too much Percocet or OxyContin is our neighbor, our kid's soccer coach, their teacher at school, right? Somebody's boss, right? That changes that dynamic a little bit, right? So it's hard, it is a little hard to say no. So what else? And then I put all the good, you know, dedicated, willing to work hard, thirsty for high quality CME, willing to take their noon hour to come to grand rounds. You know, I think if you're at Marine General Hospital and you have a great grand rounds during the day, who shows up? It's the retired people and the people that didn't have, you know, the tee-off time is at 1:30 or 2, you know, I don't know. But in a small community, people are thirsty for this information and they show up. Even the people that are some of the problem people, okay? So, and then, you know, of course, we're often, most of us in this county are under contract to a bigger agency, right? In urban areas, any doctor can start a practice in a strip mall and call it a pain clinic, right? And we don't really have a legal remedy for that right now, right? Because we're independent practitioners. But in the rural areas, they can't survive, so that's okay. So you guys all pretty much know about how we're transitioning to injection opioids. Just a few years ago, 60% of the deaths were prescription. Now 70% or so illicit. Well, there's changes in harm reduction, how important harm reduction is, which this whole conference has always been focused on. Clean syringes, naloxone, access to opioid treatment. And then what about ambulances, right? Don't we want to, we've got to have an ambulance that'll be there in 5 minutes. You know, that's important. The ER, that they're compassionate, viewed as, you know, giving high quality care. We had a gentleman got out of jail about 6 months ago here, just started using again, didn't have naloxone, came in, you know, in respiratory distress by ambulance, got intubated, got shipped out to a regional tertiary center. Did well, but, you know, near miss, definitely near miss. And the ALS service was important, right? So there's a graph. Everybody likes graphics, right? But just as you probably all have seen. So you look at any opioid here is over 13, right? And now we're down to where the natural and semi-synthetic are the prescription ones, right? There's 4, so it's down to around a third of the deaths now. And you can see the inflection point where this is fentanyl, carfentanil, etc. Right there, the one that's just going through the roof. And we know nationwide that's happening. And here's heroin has surpassed the prescription opioids as cause of death. Right? All right, so now this is a little something I think is important, kind of getting to the point of naloxone being prescribed in the provider's office and the importance of doing that, okay? Can we make family and friend administered naloxone more effective in preventing prescription opioid overdose deaths? So I'm here to advocate yes, way more effective, okay? For one thing, the evidence is not clear yet that we're saving lives with all the naloxone being, it makes sense, right? Naloxone versus an overdose, but here's the problem, okay? Family and friends administered naloxone is spectacularly successful saving the lives of injection users. Everyone knows what's going on. Person goes down, they turn blue, they're not breathing, right? There's no doubt, give them Narcan and you've saved a life, right? Here's the prescription story, right? Often alone when they most need the naloxone, right? People have gone to bed, they've left, they didn't know what was happening, the diagnosis did not get made. Why can I say this? I work in an ER and I work with the coroner's department and I read the coroner's reports, okay? So too often people don't figure out what's going on. So it doesn't do any good to have naloxone or know where the naloxone is if you miss a diagnosis. I've read the coroner's reports on people where that exact thing happened. People, even in one case, they called their friends that were paramedics, they called them out to the house. And they said, I'm really worried about Bob because, you know, he isn't himself, but he's been drinking tequila all day. And, you know, I just think, no. You know, an hour and a half later, Bob died of an opioid overdose that nobody knew he had on board. And the friendly paramedics who didn't come there officially, everyone missed it. Everyone missed it, okay? So, so this is a hot button for me. Recognition is important. And someone staying with the possible victim, okay? If there's any doubt about whether this person might be in trouble, a person needs to stay with them. They go home, right? You know, Billy Bob's going to wake up. It's not enough to just prescribe. The people with the naloxone need to understand that the prescription drug overdoses happen slowly and often go unrecognized until it's too late. So that's a little bit of my soapbox. You know, and I just go on with that theme here. This you've seen, you know, it's absolutely apparent when somebody shoots IV and they go down. Everyone knows what happened. It's easy to reverse that, okay? So this is redundant, okay? What must happen, you know, I'm just gonna run these out here so we don't spend a lot of time on it. But a capable person to recognize what's going on that stays with the person until they are absolutely 100% sure that person's gonna be okay. Okay, so I think we can save lives if people remember these points, okay?
I have a question about
Yeah,
that.
sure.
If you have someone who you're wondering what's going on and you suggest somebody stay with them, what harm would it do to give them naloxone
None.
earlier on board? Does it,
None.
but does it have an effect if it hasn't
So,
all
yeah.
been absorbed into their bloodstream yet?
Sure.
And it
So
would-
round numbers in naloxone lasts an hour, round
Okay,
numbers.
okay,
Yeah.
so if it's gonna, it would still be on board when their opiate that they've ingested orally,
Not if it's OxyContin, for example,
so long
or
after.
MS
or long
content,
after-
yeah. So
Okay.
that's or it's combined with benzodiazepines, for example,
So
long-acting
then
Klonopin.
they could
There
still
are drugs, yeah.
later in the night.
True. But, and of course, if you give the naloxone, we all know, you call 911, right?
Right.
Now, there's good evidence now, used to be that was the swab with people injecting drugs, right? And they've shown now in New York, so, and people would sign out, I don't want the ambulance, tell the ambulance to go away. And they did that, and everybody was worried that those people would then bounce back into a worse overdose. They don't.
Okay.
They save your life. In the IV overdoses, you can give the naloxone with the impunity, and if the person really feels they do not need an ambulance and they're fearful and all that, you just stay with them and make sure they're okay. That's probably okay. Prescription, I think you would really need to call the ambulance for sure. You know, personally, my take on it. Okay. Prevention of addiction. Okay, we haven't talked too much about prevention. This is really short. I'm just going to give one slide. I had to do this. All right. Harm reduction is essential, but there's more. And you know, we all want to prevent this. Come on, this is public health, right? Where most of us hear about public health and prevention, bicycle helmets, immunizations, car seats. Come on. You know. So what can we do? We understand now these adverse childhood events are hypercritical. Okay. So, but how can we mitigate them? And that's a process. In evolution, right? Shasta County, for example, is doing all kinds of stuff I happen to know, you know, in this area, and it's really amazing stuff. But the adverse childhood events, which are highly associated with mental illness and substance abuse later in life, are these items here, and you can learn more about that if you just search on ACEs as well. And then just to go ahead, so there are some evidence ways to mitigate ACEs, resulting in improved outcomes. One of the ones that caught my attention, which seems unlikely, is this BOTVIN life skills training. You know, for 15 years, that's been validated. It works. It decreases tobacco use, it decreases alcohol, decreases young people, and it's a junior or senior high school program. I'm sure there's others. I'm far from an expert. And then bullet number 2, there's this business about one caring adult. Okay, so a lot of children grow up in homes where there really isn't a reliable person, or that reliable person is sent out to jail. Now they're farmed out to foster care. You know, so it's been shown it doesn't have to be a parent or grandparent even. It could be the neighbor that has known this older neighbor, whatever. One caring adult that is with that young person for over the arc of 15 years or something is huge. Okay, and then we know teaching parenting skills and the appropriate parental response to ACEs, because of course, you know, 5-year-olds are alarmed when they see mom being beat up. And you know how mom and other adults nurture that 5-year-old to understand what just happened and how to process it can be impactful. So that's my little one slide on prevention of addiction. There's not too much I know about that. So I gave you some takeaways, and we'll have some more questions. Thought I should kind of summarize a little bit there. I'm not going to go through them. You guys know. So other questions come to mind, or topics for discussion, you know? That's what this is about, sharing and learning, and doing everything we can. This is a horrible epidemic. You know, Mark Horton, who was here yesterday, used to be public health officer with the state of California. We're talking ahead of the conference, and he was saying, well, it's like the fires. I was saying, we were talking about rain fire, right? It's like fires. You know, the fires, but why do people die in fires? Smoke inhalation. Well, harm reduction is like the smoke, you know, the smoke inhalation. People are dying from, you know, high-dose opioids, but we got a fire. We have an epidemic of addiction. We really need to pay attention to that. That's my plea, and it's hard work. There's no magic bullet. Sometimes I think people are thinking that MAT is a magic bullet. It's going to solve it. Or naloxone's a magic bullet. We're all going to be, no. Certainly, no. Yeah, it's just more complicated. There's no magic bullet. So, other questions, thoughts? Yeah.
So you do your grand rounds training and continue to engage your, physicians and prescribers in conversations. Do you talk about ACEs and like how like trauma and like some of the socioeconomic factors like impact rural communities maybe differently than urban
Well, it's
communities?
an excellent point. No, I'm actually new to ACEs. My knowledge of ACEs, I was in a meeting about 6 months ago where they really made an incredible presentation on this, and it really brought it home for me. And our providers, and then it's all about the intervention. So at Public Health, we have the First 5 program where we do teach parenting, right? And that is a key part. And it didn't come up in our meetings here, even though we're the kind of host agency, but we have a team of 4 young people, both teens and early 20s, who are involved in going into the schools, and they're not using the Botman approach that I mentioned earlier, but they are working on how to educate our young people and help them understand how to better manage when they're approached by someone like, hey, like, do you want to buy one of these pills or whatever it might be. But it's a difficult area. We got pushback from law enforcement here because they had a whole program where the deputies wanted to march in the classroom with their uniforms and guns, and you're going to die from smoking marijuana and all that stuff. Once you smoke some reefer, you're going to be an addict the rest of all that stuff. The kids know better, So we still have some of that going on. I don't know, I can talk forever, but one of the shocking things to me, I had a 24-year-old woman who was a student over at my college here who came to me because she wanted MAT, which I do, and she'd been smoking heroin and all this. She's 24 years old, she's going to college, she grew up, went to good high. She didn't understand why it was that when she used heroin every night for 10 days and the next day she was sick if she didn't use heroin. She was mystified by that. So how is it our young people are getting to be 20-something and they don't understand that if they smoke heroin every day, they're going to be sick one morning, Yeah, we're missing, something's wrong with that process there, right? And we know we're trying to do it the right way that doesn't teach them that we're lying to them, misleading them. Other, yeah.
Do you run into the issue in the medical community that physicians feel that we got our population into this by prescribing, calling it the 5th pain, the 5th vital sign of pain
Yes.
management? We got them here, so now we're giving them another drug, Suboxone, to
Yeah.
get them out of it. I run into that with our medical community in Sisseton County a lot, that they are resistant against
Right.
MAT because we got
Most
them
definitely.
there, and now it's coming from Big Pharma again to tell us to
Right.
give them Suboxone.
Well, I was a complete skeptic when I started as health officer here in this county in 14. The 2 next offices to mine were substance abuse counselors, okay? And we would talk on the way to the water cooler and whatever, and hey doc, when are you going to do Suboxone? And so I'm saying, I thought exactly that. I thought,
Like my
this is
office.
big pharma, and you've got to be kidding, this is just trading one drug for another. And then they said, well, let me give you the card for the drug rep for Suboxone. I said, no. The last thing I want in my career is more drug reps. These are the people who got us here,
Right.
So that took me about another year. And, among other things, I had a colleague who had been health officer down in Butte County who had been doing this for 7 years. We went to med school together. And he said to me, Doc, some of the most rewarding patients I've had in my entire career are the patients that I've helped with this. And it doesn't seem, and we do want to wean them. We don't want them on the Suboxone forever. And I know plenty of people who've been weaned after a year, it's usually 1 to 2 years many times, but have been weaned and very successfully so. And so, it kind of gets back to the whole thing about methadone, because methadone clinics, opioid treatment centers, which have been around for 30+ years, more than that, show good success rates, right? People stay out of jail, they go back and get a job, they get their family. So that's success, and it's kind of like the harm reduction. Can't we reduce harm for these people and not judge them for their addiction, whatever, right? Yeah, it's an uphill battle. I just happen to believe I've come to the point, and I'm willing to advocate for the point that it's better than methadone, and even methadone was better than shooting up heroin every day, and that our goal always is to ultimately get people to the point where they don't need any of that as their brain, and of course the biochemistry, I'm no neurobiologist either, but the biochemistry, what I've been told is, it's all about dopamine depletion and chronic changes that occur in the brain over the course of years of using, and it takes a while to heal.
And then when you throw like trauma into the mix and they get stuck in a certain developmental stage, right?
Yeah.
We're not developed into the limbic system. Then there's a huge problem there, right? Which where we're really trying to inform with trauma-informed care, and how we see this ACEs starting to work. Does that make sense? So we're starting
Absolutely.
with these early life experiences.
You can all hear, right? Because what do you think?
Sorry, I just want to, because I've heard some questions about the ACEs, and my background's in neuropsychology and trauma-informed care. I'm a dual diagnosis therapist, but working with people with substance abuse, I've noticed like people that tend to fall into the trap of heroin use through, hey, this is my buddy, try this drug, who has no adverse history. The chance of coming out of that is much greater versus my buddy over here who has a life experience that's just downhill or has been brought up in struggles. The revisiting of drugs is just super heavy. So, I don't know, I just wanted to chime in like in that piece when we can attack it seems like an experience, and I don't know, and please speak to this since it seems like an open forum discussion this time.
Sure, of course.
In my experience, I'd be curious to hear from others. When we attack like a kid, when we can identify earlyhood trauma and we can identify what part of the brain that kid has been stuck in trauma, and then we can address. I feel like that's a big step in prevention for drug use versus like where we're at right now with substance use. It's not. I don't feel like it's prevention as much as it's right. We're just
Putting out the fire.
putting out the fire.
Yeah, so much so. Some of us have genetics. They say 30% of people are just not addicts genetically, right? So they're fairly immune. If your buddy at high school doesn't have the genetics to be an addict, they may be able to dabble with whatever and they're fine. And somebody else, because of their genetics and because of their life experiences, they just don't have the wherewithal to be able to deal. Suddenly this release and from all their problems seem to be gone, and it's very relieving to them. So, other thoughts on that? Yeah, we have other people here that are counselors. It's wonderful.
Plumas County Public Health Agency, growing healthy communities.